It's a pleasure to meet you, Dr. Tonge.
Yeah, it's a pleasure to meet you, Dr. Osborne. So I think, could you tell me a bit about yourself and kind of how you've gotten to your practice?
Yes, and then I want to know all about you too.
Sure.
Yeah, so I've been in practice. I am a physician specializing in psychiatry. I have a subspecialty in geriatric psychiatry. I also specialize in dual diagnosis, holistic psychiatry, administrative medicine. I was a medical director for years. But my passion was always hospitalist, as a hospitalist. And so I worked with forensic patients a lot and people with serious mental illnesses. Enjoyed that work. Over the last few years, I kind of shifted more to consulting work and enjoy that. And also over the last, I guess 20 years almost now, I've been writing books about health issues that I feel will help people both with mental and physical health, help improve both. So I've written several books, and the last one was last year, and it's called Half-Life, because our mental and physical health have everything to do with how long we live, and what goes into our bodies will determine that as well. So it's a pleasure to meet you. Now tell me about you, Dr. Tonge.
Sure. So I am a clinical psychologist by training, and so that has involved both doing the research and teaching sides of the practice of psychology, and then also doing treatment. So I went to school at WashU in St. Louis in the Midwest, and really had entered into school like very focused on psychopathology and anxiety disorders, and researching those disorders, and then started to really engage with practice as part of the training and really enjoying it. And so now I'm an assistant professor at George Mason, and my research program is centered around anxiety, depression, but also mental illnesses and people who are vulnerable and hold stigmatized identities, and examining how the ways in which they make decisions about how to disclose about themselves, how to disclose their mental health, how to disclose aspects of their social identity when holding these really vulnerable and stigmatized identities. So start of my career in a lot of ways, and kind of looking forward to where it's going, starting to look more at how AI factors into, and social media factor into disclosure decisions and help-seeking decisions in treatment. Yeah.
Right. This is the new age.
It is, yeah.
This is the new age. So we wanted to talk about stigma. And I understand you have kind of two ways of viewing stigma. Can you share that with us?
Yeah, so there's, I think, a lot of the, well, you know, I also want to say a little bit too, like age-wise and like cohort-wise, like my own observations from growing up as a kid in the 90s and conversations about mental health, because I try to pull this in with my students when we watch clips, or I try to bring in things into class to explain a concept of mental health treatment or a concept like related to symptoms of a disorder. That when I pull older clips, what I notice is the you know, the language people use is language we wouldn't use today, because we have a recognition that like these are words that don't make people feel great about themselves. These are words that really create a stigmatization of mental health and seeking help for mental health, and we don't want that. We want to encourage people to be open about their mental health. It's different, the words that people use to describe themselves and their own challenges with maintaining their mental health. And so these two sides are a public stigma, and that's a really active area of research. That's maybe, I think, the area that people might think of first when they think about stigma and combating stigma, and that's the way that society at large, or on the whole, views people with certain conditions, in this case mental health conditions. And those usually encompass negative stereotypes, active discrimination, and often things that are untrue or distorted about what it means to have a mental illness. The other side that we don't talk about as much, but we find in research is very important to actually getting people help is self-stigma or internalized stigma. And so that's the process of taking all of these messages that you receive on TV or from other people and also from your family members and from professionals that says some manner of you are not worthwhile, you can't accomplish certain things, this mental illness defines you in some way, but then you believe it and you internalize it and you start to then act or change your behaviors, the ways you interact with others as a result of it. And so the self-stigma part is one that I've gotten really interested in as I've gotten older because of the ways I see it's shifted with the folks who are growing up today, especially.
Definitely. Yeah, self-stigma as in self-esteem, self-deprecating.
Yeah.
You know, even when we talk about how society stigmatizes people with mental illness, well, let's talk about that society, because within that society, those are the very people who are adverse to getting the help they need, so that they can understand what's really going on around them and what's happening to them. And so, yeah, I see stigma. I like the way you separate them, because I think that's so important that people understand that within themselves, that it can be them stigmatizing themselves, and that keeps them from getting the help they need when they need it. So, you know, a lot of times I tend to see stigma in both veins, but I see anti-stigma in both cases as improving our education about what is going on with the human body. So a lot of the very stereotypical statements I've gotten, because as a hospitalist, I would also get people asking me, how could you do that? You know, they're so sick, and oh, aren't you afraid of them? And I'm like, no, I'm not afraid of them. And yes, I have gotten assaulted, but I understand what's happening to them. I understand how sick they are. And so that never deterred me from continuing to try to help them, but at the same time I did put in certain types of protective, you know, I made sure I didn't turn my back. But so the first, an anti-stigma campaign should include, in my opinion, education. People need to understand what's happening to their bodies. I'm a holistic psychiatrist, which means I see mental illness along a complete spectrum with physical illness. I work with people who have a lot of physical conditions, and their mental health is, if I try to address one without the other, then both will go down. And so education about human physiology is very important. And then a thorough evaluation of the person. So understanding what a thorough holistic evaluation means, because I have mentored a lot of residents and other young doctors, and they will do an evaluation, but the part about what we need to actually live, like nutrition, is like a line item, and it's very abbreviated, and okay, I eat healthy, that's the end of the story. Well, what does healthy mean? Because there are now studies at Stanford going on as we speak that are addressing how nutrition affects the way, particularly anxiety and depression, but also people with serious mental illnesses. They're putting them on certain nutritional lifestyles that is not only reducing their need for medication, but in some cases eliminating the need for medication, which is, that's proactive, that's holistic. And then the third anti-stigma is understanding how to reconcile the two. So how to reconcile our knowledge, what you've now learned about physiology, which is an ongoing study, understanding of physiology, with, was this a real holistic evaluation of what I'm going through? So I feel like once people understand those two factors, then the stigma will start fading away, because they will feel, both society that's causing the stigma and the person who's stigmatizing themselves, they will understand that the self-blame will start dissipating, and they will start, with that kind of knowledge and that kind of evaluation, you become empowered. It really is empowering. And it's empowering, and it brings more hope to the situation too, because too often, you know, people come to a psychiatrist and they said, oh, well, you just do pills. You're just for meds. I'll go to my therapist for the other. I said, well, it's not one or the other. And you can't really have one well without the other. And there's more to it than either one of those two. And so when I explained to them what I mean and how, I said, I need to hear from you more about what you do during the day, what kind of foods you eat, specifically what kind of foods you eat. And most of the time they're shocked. Actually shocked. It's like, wait, I just came here for pills. What are you asking me all these other questions for?
About these other parts of my life? Really?
Well, they're surprised because they've bought into the stigma.
Exactly, yeah. And I think that part of what that self-stigma and internalizing it does is reduce your concept of yourself into maybe one thing at a time, or even in one place, you are one thing at a time. And I remember doing groups with people with schizophrenia who were older, and I think they had gotten very used to, and they also dual diagnosis, gotten very used to the language that's used within AA, that understand the history and the context of it and the intention. But then part of it, what it does for some people, is you introduce yourself as your illness. And for some, that's the first step for their recovery. For other people, it kind of sets into their brain as, I am this, that, hello, my name is, and I'm a schizophrenic. And that's your whole identity. And so then to have a doctor, I think, asking, and what do you enjoy doing in your life? It can completely flip on its head. Well, what does it mean to be someone with schizophrenia? What does it mean to be someone with an anxiety disorder? That it's with an anxiety disorder, and also with all sorts of other things, with all sorts of other interests, with aspirations, with things that you want to be and do in your life. And that, what I love is that step of assessment that you're getting at, that I really try to hone in teaching, of how important assessment is for transformation, because the questions we ask as providers signal what we think is important to know about. And if we only ask about, well, what medications are you taking, then that's the only thing somebody will see as the interaction between themselves and the medication and their illness.
And stigma gets to run amok.
Yes.
Because the information's not there, the knowledge isn't there. And the provider hasn't asked for the knowledge. So one of the things that, and I'm going to bring up medications again, because it's often, I've had very skilled psychotherapists say the same thing to me. Well, if you don't prescribe medications, then what do you do? And I said, well, I didn't say I don't prescribe medications. But what I do like to say is that I'm a healer and not a dealer. I'm not a drug dealer. And I do think that healthcare in general, part of the stigmatizing part of mental health care is that we've oversimplified and almost deminimized the human experience by saying, oh, let me give you this pill and then go on your way, and that should do fine. So I like to remind people, part of the information that accurate information, knowledge, learning about the human physiology, also learning about what you might not be getting told. And I like to bring this up because a lot of people don't know how dangerous these prescription drugs are. And no thanks to marketing, there's been a huge, I mean, you talk about building a certain type of stigma. This is a stigma, I call, of making it seem like pills are the answer for everything. And so, but what they don't tell you, even with the Ozempic drugs, which I don't prescribe, you have almost more than 2,000 people who are now legally blind because of a side effect that no one knew about. Well, that's intentional. So I like to share information that, just to give people an example of the kind of information that is important to understand, knowledge, to fight stigma and to feel empowered, to actually be empowered to make informed decisions, so that you actually know, wait a minute, maybe I should try the green meditation, the box breathing, maybe I should try, oh wait, there are some herbals. I mean, herbal medicine is far more advanced than anything we've seen in the last 100 years, but most people don't know that. The other thing people don't know, this is a 2023 study, You can find it in nih.gov, okay? And it's by Lillooet and Pitts. And what they did was they examined years' worth of drug side effects, okay, across different countries. And that they found was adverse drug reactions are estimated to be between the 4th and the 6th most common cause of death worldwide, okay? Some people, when I would say that to people, they would say, well, that's recent information. It's not recent information. So back in 2014, there was a systemic record review by Harvard University Center for Ethics, okay? And they found that 128,000 people died each year, just in this country, from drugs prescribed to them. 128,000. Now, to put that along the list of, there's a list that the CDC posts every year about the 10 most common causes of death in this country. And adverse drug reactions not on that list. But when you look at the number, 128,000, that's more than deaths from diabetes. Okay, and we know diabetes is very common. So let's go back a little further. Well, actually in 2014, another study at Harvard found that new prescription drugs have a 1 in 3 chance of causing serious reactions. That includes permanent disability and death. 1 in 3, 33% chance, okay? Let's go back further. 2003, okay? The FDA did their own review, and they found that, in fact, they monitored, and they found that the adverse drug reactions are one of the top 10 leading causes of death in the United States. So I bring this up because this is information that a lot of people don't know. When I wrote my book, Half-Life, part of the data in that book comes from the FDA. I asked for 25 years worth of data, drug side effect data from the FDA, and under FOIA, Freedom of Information Act, I was able to get it. And I analyzed all this data, and indeed, the numbers were through the roof. It was through the roof over the course of 25 years. So I think people need to understand before they jump at the first drug that comes out or come in and that's the first thing they ask me, oh, I just want this drug. I think they need to be aware that, first of all, that's not a holistic approach. That feeds stigma, and it's not what you really want. You don't want your human body, yourself, to be underrated like that, and as well as put at risk like that.
Yeah, and I think it's also, it speaks to how complicated the decisions can be, but how much I think we project a simplification of every problem. And so one of the things, a research method I've become more passionate about involves like complex systems and trying to acknowledge that the way that we conduct our research often says we look for what's one single cause or one single mechanism that's going to change something. And it really reinforces that idea of, well, there will be one drug, there will be one pill, there will be one thing that I do that changes everything. When we're a complex system, our bodies, our minds, the interactions we have with other people are all part of a complex system. And that sometimes, maybe this is like a researcher way of talking, I can't discount, I can't say that I'll ever know with 100% certainty that there isn't some one single cause. However, it might, in the moment, while we haven't found that thing, sure, some folks might still be interested in looking at it. Let's look at multi-causal and multi-system approaches and complex system approaches. Changing more than one thing at a single time. Because we don't get stigma by one person, and especially internalized stigma by one person saying, there's something wrong with you, or you're crazy, what's going on with you. It's from hearing it from multiple different people, it's from hearing it in different sources, it's from hearing it from your doctors, it's from hearing, well, we've got to prescribe you this one medication and you'll be on it for the rest of your life, and that's that. There's nothing else for you to do. Then did you take this? Did you not take this? In actuality, it's like you can take it, and then also we can work on your exercise, and also we can work on your hobbies and your social systems. That the medication that you're taking can be inclusive of other things, and there can be more that's prescribed than what pill or what drug you're taking. It can also be prescribing, well, what are you doing for yourself? What are you doing to develop
Right.
as a person? And having that as and I'm wondering if that's kind of how you view a holistic approach to medicine sometimes, is making that as an informed decision.
Right.
And how will it fit into the rest of my life,
Right.
rather than this becoming my entire life.
Right, as informed consent. I question whether or not, if people actually know the risks they're taking with these pills, if they would jump to wanting to be that to be part of the picture so early on, because there's so many other things, like you said, people are convoluted, and there's so many other facets of a person's life that, yeah, they can take it with the pill, but what I see in this culture today and over the last 25 years is it's a very quick leap to, oh, you have this symptom, here, take this pill. It's it's a very, there's not a whole lot in between.
Yeah.
And if people can recognize how complex they are, and that it's almost an insult to reduce their complaint to a pill. Yeah, that's what I see, because there's a lot of relapse, and that I think that's because we have not addressed it holistically. Right, that holistically is what I mean, exactly what you said, addressing it from multifacets and empowering people to be successful at addressing it from those multifacets. Yes, yes, you change your level of activity, change how you eat, what you eat. Let's look at that very closely, because there's a lot of foods that feed inflammation. And we even know with depression and anxiety that there's an inflammatory process that's behind those two conditions. And so if you were to remove all inflammatory foods from your diet, what do you think would happen? And why take a pill first that comes with a 33% chance of you getting very sick from it? I mean, you have to get past side effects, even if they don't kill you, but 33% chance is pretty high. And so why start out with that before you try to take matters into your own hand, change what you're doing? I mean, I would walk them through it, and they were like surprised. I mean, there's lots of resources available to help guide people through lifestyle changes that are anti-inflammatory. And I've seen a lot of success with people who have decided to do that. Now, I've got to tell you, most people have decided not to, because they're like, I'm going to have my McDonald's, I'm going to have my Taco Bell, I'm going to have my chips, I'm going to have my candy, I'm going to have my donuts, and they tell me, no, I can't stop doing that.
Yeah, yeah.
So
I think that's their choice
right,
too.
that's their choice too.
You know,
yes.
And I think what's so funny hearing you talk about this is thinking of, well, what order do, and this is something I'm very interested in, what order do people go in to seek help? Right. So do they, and what does that say, the way that you order your approach to seeking help when you have a problem? That I find that, as a psychologist, kind of being associated with like, all right, so you're going to talk to me, and then you're going to sometimes tell me exactly what to do that's going to solve our problem. I get a lot of that. I get some of well, you're a psychologist, and I didn't want to take medication, and so I'm here because we can have a bigger conversation about what I can change in my life. And I'm like, great. And we might find that later down the line, maybe that does include a way of balancing it with medication, but let's explore it together. So I do get to have that benefit of longer conversations with people, but I've also had those experiences of people then coming after. So after they're already on some sort of medication and they're coming in for a different problem and having to say, I think these two things are related, that I think you're maybe over-reliant, and sometimes it's not medication, sometimes it's marijuana. Increasingly, I'm using this to self-medicate, I'm using this to regulate, and saying, well, but are you learning new skills at the same time? So the trying to examine for each person, well, what's the totality of what's going on for you? And what are messages that maybe we've internalized about ourselves and our needs and our capabilities that says, I can't give up this thing, not because I don't want to, because I enjoy it, it's a part of my life, it's a part of, it's my life and I want to live it the way that I want to live. It's not that as the reason. It's because I've internalized this belief that I can't. That you can't. That I don't have the power to make a different decision or be a different person or approach things in a different way. And that's the reason why I'm doing this.
Yeah. Yeah, then they don't feel empowered.
Yeah.
And again, the knowledge, knowing that a lot of these foods are highly addictive. So I don't think a lot of people realize when I started dropping my carbs, I went through horrible withdrawal. There's a horrible withdrawal, and it's not just me, there's a horrible withdrawal that people will go through if they suddenly drop their carbs. But that's one type of food that can, if you have too many of them, can be very inflammatory to your system because it spikes insulin, and we know too much insulin is not good. But the other thing is, if we kind of educate, this is our physiology. We've been told, and I'm just going to bring up seed oils, because if you're adding toxins into your body that are inflammatory, and then you're giving pills to try to stop the effect of them, i.e. depression, anxiety, then yeah, you're almost committed to being on those pills for life because you haven't changed the toxins coming into your body from the food. So when you say, where do you start? Do you start with one versus the other? I see this in several parallel forms happening simultaneously. So depending on the degree and disability from the symptoms they're having, you may start something early. But depending on their understanding of the physiology, explain it to them, even give them books about it. If people can understand that if you are bringing in poisons unknowingly, we don't know we're doing this, it's just in our food system. Seed oils have been promoted as being heart healthy for the last 50 to 100 years. And the reality is how they affect our physiology has never been healthy. And that's just plain physiology, human physiology. It's not a matter of debate because it floods our bodies with so much omega-6, and most people know omega-6 is, oh yeah, we don't want too much of that. We want a lot of omega-3s, but we don't want a lot of omega-6. But these seed oils are 90% omega-6. So if you're flooding your body with something like that we know is inflammatory even in small amounts, then that's a poison, that's a toxin. So, but when you look around, a lot of the foods that it's in everything. It's in everything. And so getting away from that, how to do that, it's not an easy task, but at least recognizing that this is, if I did that, would I be well for life? Instead of having to take pills for life, instead of having to see a therapist for life, would I be well on my own? And I can tell you, a lot of people have had success like that. Yeah.
I think one of the model I got introduced to when I was working in the Department of Veteran Affairs that this reminds me of is the recovery model. Are you familiar with this? Yeah, I worked in SMI. And I think it really started in community treatment centers and from community-based approaches, and then kind of rose up from there. But seeing a recovery model of care and approach to care as an alternative or slightly in opposition to a medical model that really looks for, well, what's the diagnosis, what's the treatment, what's the cure way of looking at things. And the recovery model instead saying, well, what's going on right now, and acknowledging things might be going worse or in a direction you don't really like for a little bit, and then it can go better, and you're a part of that, and that you can drive it towards getting better after it's going worse for a little time, and that recovery is a wave, and it's not going to be something that goes in one direction at one time. You can go backwards, you can go forward. So sometimes I would, when working with folks with serious mental illness, we'd draw what our path of recovery looked like. And I draw, like, here's the straight line that people tell you it's supposed to look like, but use a different color marker, put what it is for you. And I think about that with trying to educate on that aspect for everyone, that with anything, we're, I think, often going through ebbs and flows of, no, this is the problem that will, and if we just solve this, then we will be able to have a more holistic and more empowered and better lives. And then you can put a lot of focus into that thing, and then something else kind of falls by the wayside. Sure. I see it with social media right now, and I think there's great reasons to reduce social media, and it's not the only thing that will be like, and now I stop, you know, I uninstalled Instagram and Reddit and TikTok.
Good for you.
And great, now I'm healthy. And I'm healthy forever. It's always going to be recovery. It's always going to be the ebbs and flows, and getting used to, I think, viewing our lives within these ebbs and flows of trying things that work, and acknowledging that they might not work forever. And you might have to shift and keep trying new things and keep trying to adapt and make changes. That we're not static people, so why should our cures and our approach to care
completely
be
agree.
static?
Now, you had said something earlier, and this is actually a very common thing that that I know doctors say to their patients, is that you'll need to be on it
for the
rest of your life.
Yeah, yeah.
You'll need to be on it for the rest of your life. I just think that's so unfair.
Yeah.
Because that, by the way, I think that feeds stigma. For you to tell somebody here at this point in time that, oh, nothing you can do, okay? There's no, you don't have any power to take control of this situation and make changes in your lifestyle to the point where you would not need this anymore. That's unfair, because I have seen people come off pills, and I've seen them, and I don't think I've ever said to them, rest of your life, what am I saying to you? No, so yeah, I hear you. Yeah.
Yeah.
Wow.
Yeah, it's, I feel like a big part of, I think, being like a clinician, educators, that sometimes the public stigma side, I think I really love seeing the campaigns over time that have shifted towards getting young people really invested in, well, how do we reduce stigma? How do we kind of try not to, like, flippantly, when I was a kid, flippantly use like crazy to call everything and everybody? How do we reduce that from our vocabulary so that we're more compassionate and more understanding? And I see that a lot in Gen Z and Gen Alpha. But what I don't see as much is, like, in providers too, what are you doing to perpetuate stigma? Like, how are we training students? How are we training residents? That perpetuates these ideas, and how are we changing our language to try to be able to empower people themselves to think of things that they can be doing to help themselves and better themselves in combination with our care. It's like, not to take us completely out of it. We can also, but we're adding to information. We're not the sole source of information.
Right, and I think that piece is something, if we can help people understand, we do not know it all.
Yes.
And do not take what I tell you, and I tell them, do not take what I tell you as gospel. Hear what I say, question it. Just like you need to question, you know, too often people associate authority or perceived authority with honesty and morality. And sorry, but I tend to see it tends to happen a little differently from that, because authority seems to come with, is very profit driven. And I don't, as a patient, I know, you know, people don't necessarily want to hear all that, but that's the reality. And so I always encourage my patients to ask me questions. You know, I will give you references, resources, and any question I really don't have the answer to, I can kind of point you in the right direction as to where to find it. You know, I keep thinking of some old commercial where it used to say, an educated consumer is our best customer. I'm trying to remember what commercial that was, but it was a commercial. Well, yeah, I think it might have been before you talked. But it was, oh gosh, it was something they were selling, and they said like, an educated consumer is our best customer. But in reality, I'm thinking, in healthcare, an educated patient is critical to fighting stigma. It's critical to reducing these adverse drug reactions. It's critical to holistic health, to, I mean, lifestyle changes. People should be aware that you don't have to stay stuck doing what you're doing now. So you actually have the power, and we'll help you with the resources to do things differently. And, you know, lean on other people that you love to help you do things differently, because people need support outside of doctor care. So I just, yeah, an educated patient, to me, is the answer to stigma, to being anti-stigma. Yeah,
and I think more of us as providers too, trying to advocate for that message, that it's a two-way conversation, and that's how we can, I think, open up the pool of solutions that are available, and not have to over-rely on just looking for one at a time. Yeah, absolutely.
Absolutely. Wow. So we really could be working together.